Hi, my name is Paxton, and my workshop is Review of Anatomy, Palpation, and Modalities of the Upper Quadrant to Treat Neuromuscular Dysfunction. We're going to start with an anatomy and palpation review. The first thing we're going to talk about is the shoulder, which includes the sternoclavicular joint. The bony landmarks are the clavicle and the sternum. The movements of this joint are elevation, depression, protraction, retraction, posterior rotation, and anterior rotation. The musculature of the sternoclavicular joint include the pec major, pec minor, deltoid, and trapezius. We also have the scapulothoracic joint, which includes the scapular and the thoracic. Gliding movements include elevation, depression, abduction, and adduction. The rotation movements include internal, external, upward, and downward. And the tilt movements are anterior and posterior. The scapulothoracic joint musculature are the rotator cuff muscles, which include the infraspinatus, teres minor, subscapularis, and supraspinatus, as well as the teres major, the rhomboids major and minor. We also have the acromioclavicular joint, which includes the clavicle, coracoid process, acromion, humerus, the coracoacromial ligament, the coracoclavicular ligament, and the acromioclavicular ligament. These movements include the anterior, posterior, and superior and inferior movements. The musculature of the acromioclavicular joint are the deltoid, the trapezius, and the pectoralis major. The deltoid has three parts: anterior, lateral, and posterior. We also have the glenohumeral joint, which includes the glenoid fossa, the scapula, the head of the humerus, the greater tuberosity, and the long head and short head of the biceps brachii. This movements of this joint include flexion, extension, abduction, horizontal abduction, adduction, horizontal adduction, internal rotation, and external rotation. The musculature of the glenohumeral joint are the rotator cuff muscles and the deltoid.
The first joint we're going to talk about is the sternoclavicular joint, where the clavicle meets the sternum. To palpate the clavicle, have the patient raise their arm above their head. You'll be able to feel the clavicle elevate and posteriorly rotate. The musculature of the sternoclavicular joint involve the pec major, the pec minor, deltoid, and the trapezius muscles. The pec major runs from the medial clavicle to the lateral humerus and takes up the whole chest. The pec minor lies underneath and is connected to the ribs and the coracoid process, which is seen here in the circle. The deltoid has three parts: anterior, lateral, and posterior. The anterior connects to the lateral clavicle and runs down to the deltoid tuberosity. The lateral runs right in between and connects to the spine of the scapula and down to the deltoid tuberosity. The posterior connects to the spine of the scapula and also runs down to the deltoid tuberosity. And the trapezius connects to the top of the clavicle, goes up the neck, runs along the superior scapula, and runs down the back. The bony landmarks of the scapulothoracic joint are the spine and the thoracic, and the scapula. Here you see the spine of the scapula. This is the medial border, inferior angle, lateral border, and superior border. The muscles of the scapulothoracic joint involve the rotator cuff muscles, such as the infraspinatus, which originates at the medial border and runs to the greater tuberosity, seen starred. We also have the teres minor, which is below the infraspinatus and connects to the inferior angle and also runs to the greater tuberosity. We also have the supraspinatus muscle, which is above the spine of the scapula and lays on a groove in there. And it runs from the superior angle, superior border through the acromion and coracoid process. Then we have the subscapularis, which can be seen underneath the armpit on the other side of the scapula. You may have your patient lay down on their back with their arm raised to be able to see this better. Other muscles of the scapulothoracic joint are the teres major, which also runs from the inferior angle, but comes through and underneath the humerus. We also have the rhomboids major and minor, which connect to the medial border and connect to the spine. The movements of the scapula involve elevation, depression, abduction, adduction, which is also known as retraction. The next joint we're going to discuss is the acromioclavicular joint that connects the clavicle, the coracoid process, and the acromion together. To palpate the clavicle, we talked about it runs across the chest. You can have them raise their arm. The coracoid process is just distal to the acromion. The ligaments of the acromioclavicular joint include the coracoacromial, which connects the coracoid process to the acromion. And to find the acromion, you can palpate the spine of the scapula and run your fingers to the top of the shoulder. The next one is the coracoclavicular ligament, which connects the coracoid process to the clavicle, seen here. And the last one is the acromioclavicular ligament, which connects the acromion to the clavicle. The muscles of the acromioclavicular joint include the deltoid, the trapezius, and the pectoralis major. We discussed the deltoid earlier. It has 3 parts. We also discussed the pec major earlier and the trapezius muscle. The next joint of the shoulder is the glenohumeral joint. We have the glenoid fossa where the humeral head sits. We have the scapula, which we've discussed. And we also have the head of the humerus and the greater tuberosity. The greater tuberosity is seen starred. This is where the rotator cuff muscles insert. The glenohumeral joint is also where the long head and the short head of the biceps attach. The long head runs up between the acromion and the coracoid process, and the short head attaches to the coracoid process. The musculature of the glenohumeral joint involves the rotator cuff muscles, which we've already discussed, and the deltoid.
So now we're going to move on to the elbow flexors. We have the bicep brachii short head, the bicep brachii long head, as well as the bicep brachii distal tendon, and the brachialis and the brachioradialis. The elbow extensors include the tricep brachii long head, the tricep brachii lateral head, the tricep brachii medial head, and the inconius. The lateral aspect of the elbow includes the capitellum, the lateral epicondyle, the radius, the radial head, the annular ligament, which wraps around the radial head, and the radial fossa. The muscles of the lateral aspect are going to be the extensor carpi radialis longus, extensor carpi radialis brevis, the extensor carpi ulnaris, the extensor digitorum, and the supinator. We're discussing these here in the elbow, even though some of their actions may be to extend the wrist because of where they originate on the lateral epicondyle. The medial aspect of the elbow bony landmarks are the trochlea, the medial epicondyle, cubital tunnel, where the ulnar nerve runs, the coronoid fossa, the ulna, ulnar tuberosity, and the olecranon. The medial aspect musculature include the flexor carpi radialis, the flexor carpi ulnaris, the palmaris longus, the flexor digitorum superficialis, and the pronator teres. Again, these are discussed within the elbow because of their origin on the medial epicondyle.
The elbow flexors involve the bicep brachii, the brachialis, and the brachioradialis. We've already discussed the long head and the short head of the bicep brachialis, but here you can see the distal tendon. We also have the brachialis, which runs underneath the bicep and comes from the distal humerus to the ulnar tuberosity. Then we also have the brachioradialis, which comes from the lateral supracondylar ridge of the humerus and down to the radial styloid, which you see circled. The extensors of the elbow are the tricep and the inconius. The tricep has 3 parts. It has the medial head, which inserts at the olecranon of the ulna and originates in the distal part of the humerus. Then we have the long head, which connects to the inferior angle of the scapula and inserts to the olecranon of the ulna. And then we have the lateral head, which originates at the posterior aspect of the humerus and also inserts the olecranon of the ulna. We have the anconeus, which originates at the lateral epicondyle of the humerus, which is circled, and inserts on the olecranon process or the ulna surface. The bony landmarks of the lateral elbow are the lateral epicondyle and the radial head. The circle is the lateral epicondyle, and the line are where the radial head and epicondyle meet. The annular ligament wraps around the radial head. You can have your patient's arm palm up, and you can even feel the radial head rotate as they move from palm up to palm down. You can even see the radial head rotate. One more time. Here we have the muscles of the lateral aspect of the elbow. The first one is the extensor carpi radialis longus, which runs from above the lateral epicondyle to the second metacarpal. Then we have the extensor carpi radialis brevis, which comes from the lateral epicondyle down to the second metacarpal. We also have the extensor digitorum, which comes from the lateral epicondyle down in between the ulna and the radius and to the fingers. This helps extend the fingers. For extensor carpi radialis longus and brevis, you can have your patient extend their wrist and abduct. Then we have the extensor carpi ulnaris, which comes from the lateral epicondyle to the base of the fifth metacarpal. To find this muscle, you can have your patient extend their wrist and adduct. Then we also have the supinator. This lies underneath all of them and comes from the lateral epicondyle across the back of the arm to the anterior portion of the radius. For this, you can have your patients resist supination. The bony landmarks of the medial aspect of the elbow that can be palpated are the olecranon, the medial epicondyle, and then here we have the cubital tunnel groove where the ulnar nerve runs. And you can actually do Tinel's and tap it, and that's how you can figure out if you have any ulnar nerve problems. Flexor carpi radialis, flexor carpi ulnaris, palmaris longus, flexor digitorum superficialis, and the pronator teres. The flexor carpi radialis comes from the medial epicondyle and goes down to the base of the second and third metacarpal. Then we have the flexor carpi ulnaris, and that also comes from the medial epicondyle down to the hook of hamate. And the carpals down on the ulna side. We also have the palmaris longus, which runs in between and spreads to the fingers. To palpate the flexor carpi radialis, you can have your patient flex their wrist and abduct. Then, to find the flexor carpi ulnaris, you can have them flex and adduct. To palpate and find the palmaris longus, you can just have the patient flex their wrist. For the flexor digitorum superficialis, it's a big muscle that runs all the way across the forearm, and it flexes the fingers. So to help find that, you can flex fingers, and you can clearly see his work. For the pronator teres, it runs from the medial epicondyle across the arm to the radius, and to find that, you can just have the patient resist palm down. So the wrist and hand bony landmarks are the radial styloid, the ulnar styloid, and the carpals, specifically the scaphoid, which forms the snuff box. The wrist and hand flexor musculature we've kind of already talked about due to them originating at the medial epicondyle of the elbow. We have the palmaris longus, the flexor digitorum superficialis, the flexor digitorum profundus, and the flexor pollicis longus. The wrist and hand extensor musculature, again, we discussed due to their origin on the lateral epicondyle. We have the extensor indicis, abductor pollicis longus, extensor pollicis longus, and extensor pollicis brevis. The abductor pollicis longus, extensor pollicis longus, and extensor pollicis brevis may cause de Quervain syndrome. The bony landmarks of the wrist are the radial styloid circled and the ulnar styloid circles. Those are very easy to find. And then the scaphoid, which is right underneath the radial styloid, kind of where that line is. The wrist flexors are the palmaris longus, flexor digitorum superficialis, flexor digitorum profundus, and the flexor pollicis longus. We discussed the palmaris longus and flexor digitorum earlier because of their origin on the medial epicondyle, but the flexor digitorum profundus originates on the anterior aspect of the ulna and comes across the hand and into the fingers. To find this, you can just have your patient flex their fingers. You can clearly see his working. You also can have them relax, and to find the flexor pollicis longus, have them flex their finger and you'll be able to see it kind of working. It originates on the anterior surface of the radius and comes to the base of the thumb. More extensors there is are the extensor indicis, abductor pollicis longus, extensor pollicis longus, and extensor pollicis brevis. To find the extensor indicis, have your patient point their finger. It runs across the ulna and the tendon runs to the finger. You can see his working. Point your finger. Next, we have the abductor pollicis longus. You'll have the patient move their thumb out to the side. Relax. Keep going. And you can see his working. Next is extensor pollicis longus. You can have your patient give you a thumbs up. And yeah, again, you can see his working. Do it one more time. Then we have the extensor pollicis brevis, which it runs along the same part as the longus from the posterior surface of the ulna, but it stops at the proximal portion of the thumb, whereas the longus goes to the DIP.
So now we're going to go over some different modalities that may be seen in occupational therapy session. PAMS can be used in preparation for occupation-based activities or interventions that enhance and improve occupational engagement. And PAMS is also known as physical agent modalities. Modalities support occupations through maintaining muscle mass or increasing muscle strength, gaining range of motion, managing spasticity, decreasing muscle spasms, decreasing edema, helping or increasing muscular reeducation, and combined occupation-based activities with modalities can facilitate outcomes and strengthen the response. So you want to include modalities with occupation-based activities. So the first one is a hot pack. The benefits can be reducing tightness and pain, increasing blood flow, increasing rate of cell, increasing cell metabolism, and the parameters are 104 to 113 degrees for a therapeutic effect. You want 6 layers between the hot pack and the skin to avoid burning. You also want to combine stretching while applying heat to increase therapeutic effect, and you want to heat for 10 to 20 minutes. Some precautions and contraindications include skin integrity, an open wound, loss of sensation, acute healing or inflammation, tumor, or cognition. Obviously, cognition, they'd be able to tell you if the heat was too hot or if anything was uncomfortable. When it comes to heat will worsen inflammation and edema, so you want to avoid it on acute healing where there's already plenty of inflammation. An open wound, due to not having insulation from the skin or enough adipose tissue, you want to avoid heating that area. Loss in sensation, again, the patient may not be able to feel how uncomfortable it is or if it's too hot. And a tumor, you don't want to increase blood flow and increase malignancy to that area. The next one is ultrasound. The benefits could be deep heating, joint capsule, facilitating healing of soft tissue, or wound healing. A superficial effect parameter would be a depth of 1 centimeter to 2 centimeters with a higher frequency of 3 megahertz. Higher frequency means that more energy is being absorbed. A deep effect parameter would be the depth of 5 centimeters or a lower frequency of 1 megahertz. The duty cycle is a period of time the sound energy is being delivered. 100% is for a thermal effect. 50% is for possible thermal effects, but literature hasn't shown whether or not the thermal effects are consistent or if it's just dependent on other parameters. And then 20%, which is most often used, is for non-thermal effects, or at a ratio of 1 to 4. This means that 1 wave is off and 4 waves are off, and this allows for more rest and ensures a non-thermal effect. A non-thermal effect can be beneficial for wound healing and tissue repair, and to achieve this, you want the settings to be low intense and pulsed. Superficial healing is most often used for soft tissue, and deep ultrasound is used for joint capsule tightness. Application technique of ultrasound would be applying ultrasound gel and applying continuous movement of the sound head to ensure that you're not heating one area too often. Precautions and contraindications include cognitive ability, loss of sensation, children, pacemakers, malignant tumors, and reproductive organs. Again, you don't want to apply ultrasound to somebody who may not be able to tell you if it's uncomfortable due to their cognitive ability. Loss in sensation, again, they won't be able to tell you if it's overheating or discomfort. Children, you'd want to avoid ultrasound over the growth plates. It may damage or cause premature fusion of the growth plates. Pacemakers, the ultrasound may affect normal function of it. Due to malignancy of tumors, you want to avoid ultrasound in those areas. And there's a lack of evidence on the effects that ultrasound may cause to reproductive organs. So we want to avoid those areas. Instrument assisted soft tissue mobilization may mean any type of soft tissue mobilization used with an instrument. This could be scraping, this could be cupping, but today we're going to talk about specifically scraping. So the benefits of soft tissue or instrument assisted soft tissue mobilization are realigning and reorienting scar tissue, reducing tightness, increasing blood flow, increasing motion, and decreasing edema. Again, we're going to talk specifically about scraping today. So you want to um, provide this treatment for 90 seconds to 5 minutes for tissue regeneration and healing. You can prep the skin with wet or emollient or cocoa butter would be a good thing to use, any type of lotion, or you can scrape with dry skin, but again, it might be very uncomfortable for the patient. The parameters, we have a treatment rate, which is the speed of the technique. There's fast and feathering, slow, which causes neurosensory benefits, fluid capture, which causes mechanical benefits, and then shearing and tangential. The treatment vector, which is the direction of the scraping, myofascial chains, linear, nonlinear, and angular or oblique. Other parameters are the depth of the treatment. We have angle of approach, which is perpendicular with the tool, and pressure, which is grading of touch with the tool. The grading scale used below is grade 1 to 3, which is very light pressure or 30-degree angle of the scraping tool. Grade 4 to 6 or moderate or firm, 45-degree angle of the tool. Grade 7 to 8 is firm in between 45 and 90 degrees, and grade 9 to 10 is deep with 90-degree angle and max pressure. Some precautions and contraindications would be compromised tissue integrity, open wound, or infection. Obviously, you don't want to scrape over an infection and make the skin worse. Deep vein thrombosis, you want to avoid blood flow to this area, as well as cervical carotid sinus. You don't want to increase blood flow in these areas. Again, if deep tissue tumors, you want to avoid blood flow to avoid growth of the tumor, and then inability to communicate. Again, they won't be able to state the discomfort they're experiencing. Neuromuscular electrical stimulation, the benefits can be to facilitate muscle contraction, and it can also be used on innervated muscles. The parameters, amplitude, strong enough to cause tolerable muscle contraction. The frequency for smooth contraction are 35 hertz, and for muscle fatigue, it's 50 hertz. Pulse duration for smaller muscles is 150 to 200, and for larger muscles, it's 200 to 300. The intensity is 10% of max voluntary contraction. Other parameters include the duty cycle. A 1 to 3 ratio or higher allows for recovery, and a 1 to 5 ratio for strengthening. And the ramp time, which is the amount of time it takes for the muscle to meet full contraction, is 1 to 2 seconds. You can complete neuromuscular electrical stimulation for up to 30 minutes if time allows. The application is the first electrode is placed over target muscle belly, and the second electrode is placed distally near the muscle attachment. The 1 to 3 ratio is 10 seconds on and 30 seconds off, and the 1 to 5 ratio is 10 seconds on and 50 seconds off. Transcutaneous electrical nerve stimulation benefits are to reduce pain and used for acute injuries. Electrical stimulation of motor fibers causes the release of opioids in the CNS to naturally block pain signal transmission. So this is how it reduces pain. The parameters for specifically pain, as you can see in the chart below, there's other parameters for different uses of it, but today we're going to talk about for pain specifically. You're going to position the electrodes on and around the painful site. You can complete with a pulse frequency of 100 to 150 hertz and a pulse duration of 50 to 100. Intensity is set to a sensory level stimulation, so where the patient is able to tell you that they can feel the stimulation, and duration as long as needed for pain. Some precautions and contraindications are cardiac pacemakers due to the effect that they may have on the pacemakers, carotid sinus, which it may cause hypotensive incident and cardiac irregularities. Again, with cardiac arrhythmias, it can make it worse. And then with cancer malignancies, you want to avoid the growth and the malignancy of the tumor. And loss of sensation, they won't be able to tell you when they can feel the stimulation. So here we have dry needling. Some anticipated results are decreased pain, decreased muscle spasm, increased tissue extensibility, increased physiological range of motion, increased strength, and increased blood flow. The parameters for dry needling are stated below. Due to the lack of research, these are just what was found and used often, but there needs to be more research to determine the different effects of different parameters. But this is just what current literature is showing right now. So for frequency, inserting multiple needles for 10 to 30 minutes is common practice. This is kind of a fun little fact that I found, that a brief single needle for trigger point is only suboptimal versus multiple needles for 10 to 30 minutes paired with electrical dry needling. So this just shows that one needle directly into a trigger point isn't going to do as much as multiple needles for longer periods of time paired with other modalities. Dry needling can have a biochemical, biomechanical, and an endocrinological and neurovascular change. And to create these changes, you want multiple needles for long periods of time. There's low dosage, moderate dosage, and high dosage. Low dosage is for initial treatments of 5 to 10 needles. You'll do superficial needling and basic deep needling. Moderate dosage are for those who have had previous dry needling experience. You might use a possible deeper technique with moderate manipulation, such as twisting the needle or removing the needle in and out in a piston technique. And you may introduce electrical stimulation and use up to 20 needles. A higher dosage is for significant experiences on a healthy individual. You can use deep techniques with a higher manipulation and use electrical stimulation for long periods of time. This may include up to 21 needles or more. The benefits of muscle relaxation is caused by reduced endorphins. And then the neuropathic pain, or the benefit of reducing pain, is due to the release of different chemicals that inhibit pain impulses. When introducing electrical stimulation, you may use low intensity and low frequency for central pain modulation. A frequency between 2 to 4 hertz with high intensity is used for muscle relaxation, and a frequency between 80 to 100 hertz reduces neuropathic pain. So some absolute contraindications include needle phobia, absence of willingness, inability to get consent, acute medical conditions, and infection. Some relative contraindications are abnormal bleeding conditions, hepatitis, diabetes, children, physiological state, and vascular disease. Due to diabetes, dry needling can increase their blood sugar, but if regulated correctly, it may be okay to still dry needle them. So here we have AOTA and the scope of practice. In policy E18, interventions to support occupation, AOTA stated that the use of interventions to support occupations may include the application of PAMs, mechanical modalities, and instrument-assisted manual modalities, such as dry needling and other new and emerging techniques. This just shows that AOTA has stated that dry needling may be used by occupational therapists as an instrument-assisted modality within our scope of practice. Here we have a demonstration on lateral epicondylitis and shoulder impingement. So as you can see here, she is targeting the radial nerve, which is 2 fingers below the lateral epicondyle. She places a firm pressure on the tube that the needle's in and places a firm tap to the needle. When it comes to nerves, you're not really going to manipulate the needle at all. You're just going to let it sit in the nerve, because needling a nerve can be very uncomfortable. Here she's targeting some of the muscles that originate on the lateral epicondyle. And she's palpating for trigger points that she may feel or any painful spots the patient may say they have. Here she's found one. And again, she places a firm hold and taps in the needle. As you can see, she's manipulating the needle into the trigger point with a piston technique. And again, she's just targeting muscles and trigger points that she may have felt. And as you can see, she's manipulating the needle deeper till she finds the trigger point. And here she's twisting the needle and seeing if the muscle grabs, but it looks like it didn't. So here she's dry needling the bicep for shoulder impingement. And again, she's feeling for trigger points. She's placing the needle into the muscle until she feels a response from the trigger point and manipulating the needle into that trigger point. Here she's twisting the needle. A second needle is being placed distally in the bicep. So now we're introducing electrical stimulation to the needles, and you're just going to turn it on low and slow to channel 1 until the patient tells you that they feel the stimulation, and you should be able to see it on the needle, which you will be able to see it in the demonstration. Here you can see the stimulation being applied. This is going to help contract the muscles to allow for reduced pain. So here she's feeling for the tendon. She's opening the arm and moving the shoulder so it's open so she can get into the gap to be able to feel for the bicep tendon. You'll know you've hit the tendon when you feel a gummy sensation, almost like the needle sticking to tape, which is what she's discussing right there. So it feels like it's sticking to tape. And then again, with a tendon, you won't really do as much manipulation. You're kind of just going to put it in, create a lesion, and remove the needle. So here we have a case study. A 25-year-old left-hand dominant female who enjoys working out, swimming, and playing pickleball has complained of left elbow pain for 2 months. She states the pain is dull, achy, and occasionally sharp with use. She states the pain at 5 out of 10 at rest and 9 out of 10 with use. She indicates that her pain is on the outside of her elbow and runs down her arm into her wrist. She reports not being able to participate in her leisure activities and states that the pain is keeping her from spending time with her friends. She also mentions that she's a server at the local restaurant and has had to stop working due to her inability to carry a tray. She stated that Tylenol and ice help relieve the pain for short periods of time. She went to her family doctor who referred her to an occupational therapist for treatment. Her doctor mentioned that if occupational therapy does not help alleviate her pain, she may need a corticosteroid shot or surgery. She has a follow-up visit with her physician in 6 weeks. So what functional outcome measures would you complete during the patient's evaluation? These may include range of motion, passive range of motion, strength, and then any functional outcome measures such as the upper extremity, the PSFS, What standardized assessments would you use during the patient's evaluation? You could complete the DASH. That would be a great one. What orthopedic special test would you complete to determine why she's having pain? There's the Mills test. That's a good one. What muscles are involved? What muscles are involved? We have the extensor carpi radialis brevis, the other extensors, the brachialis, and the brachioradialis. What performance deficits would you expect them to have? Well, due to pain, you may have a lack of elbow flexion, wrist flexion, avoid pinching and gripping, that they may feel reduced strength with pinching and gripping. They may have loss of strength. How can dry needling alleviate her pain? As seen in the demonstration, you would target trigger points or tight muscles to increase blood flow to this area, as well as cause lesions into the muscle. When you target a trigger point, it allows for the muscle to contract and relax and allows for the muscle to reset. So she is back from her first treatment session and is still experiencing pain. As her occupational therapist, you discuss her options, including dry needling. Her occupational therapist, you discuss her options, including dry needling. She says she's heard about it and is willing to try. Once you have the patient sign the release form, you begin. What specific areas should be targeted when you use dry needling? Possible radial nerve, extensor carpi radialis brevis, brachioradialis, and the brachialis. What dosage and parameter should you use? Since it is a new patient with no experience of dry needling, you would want to complete low dosage. What precautions and education would you provide your patient following dry needling? One really important one is drinking lots of water, as well as education on possible workstation, avoiding repetition of movements, and avoiding wrist extension, flexion, pinching, and grip. You'd also want to inform them that they may be sore or stiff. The patient returns the next session with decreased pain. She states her pain is a 2 out of 10, and she states that she's been able to use her left arm during basic ADL tasks without increased pain. You complete dry needling before beginning strength exercises. What strengthening exercises can you complete without increasing pain in the lateral elbow? This says think distal, but it should say think proximal. You could possibly do endurance exercises of the shoulder to ensure that their proximal muscles are staying strong, as well as possible posture improvements, especially since she's carrying a tray. She may have some scapular winging, and you may want to strengthen the rotator cuffs to help with posture. Patient comes to the next session with no reported pain. What should her focus be before discharging the patient so she is successful at home? A home exercise program is very important. How can you make treatment sessions functional and include her occupations? You can include different treatment sessions where she has to carry a tray, has to complete work exercises, recreate what she does at work, recreate her leisure activities to ensure that she's having no pain with all of the activities she completes. The patient reports that she's able to complete all her ADLs without pain. She has met her goals of decreased pain and improved strength and has returned to work. The patient was discharged from OT. So here's case study 2. A 22-year-old right-hand dominant male who plays college lacrosse has been experiencing severe pain in his right shoulder. He's been unable to practice and is worried he will miss games. He reports his pain is a 5 out of 10 at rest and says it increases to a 10 out of 10 when he tries to play lacrosse. He says the pain affects his sleep because he sleeps on his right side. He states that he's struggling to go to class because of pain and is constantly uncomfortable. He also enjoys working out and is expected to do so for lacrosse, but has had to stop due to the pain. The patient states that his main concern is getting back to lacrosse. So what are some functional outcome measures you could complete during this patient's evaluation? You could complete the patient-specific functional scale, as well as range of motion and upper extremity functional index. You may complete like pinch and grip, MMT to figure out what their strength's at. What standardized assessment would you complete during this patient's evaluation? Again, the DASH would be a great one. What orthopedic special test would you complete to determine why they're having pain? Hawkins-Kennedy, near impingement relief. What muscles do you think are involved? The bicep or the bicep tendon? What performance deficits would you expect them to have? Loss of range of motion, loss of strength, reduced tightness. It may be hard to carry stuff. It may be hard to flex the elbow, may be hard to reach above their head. How can dry needling alleviate the pain? It can increase blood flow, reduce tightness, and it can create lesions in the tendon to also increase blood flow. He is back for his first treatment session and is still reporting pain. His occupational therapist, you discuss his options, including dry needling. He says he's willing to try anything. Once you have the patient sign the release form, you begin. What specific areas should be targeted when using the dry needling? The bicep and the bicep tendon. What dosage and parameters should you use? Again, low dosage, but since he is a healthy 22-year-old athlete, you may include introduction to stimulation. What stretches should you give the patient following dry needling? You want to avoid doorway stretches because of how the humeral head sits during a doorway stretch. As long as they're at a 90-degree angle and the humeral head's not rotating forward, a doorway stretch may be used. You could do a wall stretch, as well as posterior capsule stretch, and maybe even possible upper trap stretch. What precautions and education will you provide to your patient following the dry needling session? Again, you may want to inform them of avoiding overhead repetitive movements, to drink lots of water, and that they may be sore. The patient returns to the next session with decreased pain. He states that he has been able to use his right arm with less pain. He rates his pain at a 3 out of 10. You can complete dry needling before beginning strength exercises. What strengthening exercises could you complete without increasing pain in the lateral elbow? Think distal. You may complete wrist strength and you may complete elbow. You do need to be aware that the distal tendon and the bicep play a role in shoulder impingement, so you may want to ensure that they don't have pain when completing elbow exercises, and it may be more beneficial to complete elbow exercises in neutral. The patient comes to the next session with no reported pain. What should you focus on before discharging the patient so they are successful at home? A home exercise program is always beneficial for them to take home. How can you make the treatment session functional and include his occupation's end goal of returning to lacrosse? Have him bring a stick to a treatment session and you can play lacrosse. He can catch a ball. That will allow you to see the way he throws, to see the way he catches, to see why his shoulder impingement was caused, to hopefully avoid that later on. It's also great to include lacrosse to ensure he's not having any pain before releasing him. The patient reports he can use his arm without pain. He has met his goals of decreased pain and improved strength. He has practiced, worked out with the team, and returned to ADLs without increased pain. The patient is discharged from OT. And here are my references. Thank you.